Ed, welcome to the Xccelerate podcast. Tell us a little bit about yourself.
Happy to. I'm Ed Clark. I'm the Vice President and Chief Medical Officer for Banner Health Plans and Networks. I've been in this role for 6.5 years. For those that don't know, Banner Health, we're located mainly in Arizona. Our headquarters is in Phoenix. We're a payvider. Started out as a hospital system with clinics, urgent care, the whole gamut, and currently have about 1.2, 1.3 million members or lives in risk-based contracts, some in plans we wholly own, others in JV, and then others through relationships with PCPs and others through our clinically integrated networks in Arizona. We have a few markets there, and then Colorado. And so I have the pleasure of having lots of great folks on the team to help providers just kind of transform the way we take care of members to create good outcomes and lower costs. So really pleased to be here with everyone.
Great. And you mentioned clinically integrated networks. You mentioned accountable care organizations. I assume that's incredibly data intensive and technology intensive. Tell us a little bit about what you think are the most important building blocks of what you put together in order to make your program successful.
Be happy to speak to that. So, when you kind of wear as many hats as many on our team do, really making sure that, the platforms and the teams you have can help segment all the various members in these contracts into the right compartmentalized buckets so that you, for example, can make sure you're looking at the right, let's say, United Healthcare contract in, let's say, the Tucson market versus one of our markets in Colorado or one of our ones in Phoenix. And so the ability to ingest those claims files, compartmentalize those, make sure you've got the attribution right, and then kind of group those by market is absolutely critical. So without being able to do that, we really can't run the programs because otherwise everything would just be one big giant mess, right? So you have to have that nailed so that we as leaders can look at, how we're performing on those contracts, what are the health outcomes, clinical indicators for those members, but more importantly, making sure that then those data also inform the decisions made by our, let's say, our care management teams, our leaders on the care transformation teams that are out on the ground interacting with the practices, but most importantly, those providers at the point of care. So, are we able to serve up the information for them that's timely and on the right patient or member so that they can take action? So, it's table stakes at this point, right? You've got to have a way to do that effectively, especially if you want to kind of grow to get to the scale that we're at there.
So Ed, that sounds incredibly complex. It sounds like there's a lot of different activities that the clinicians have to do. And like me, you're a physician.
Mm-hmm, correct.
What do your physicians say about this paradigm of having to operate in a value-based care model? Do they have all the tools and technology that they need to be successful? And if not, what else do you need to bring to bear in addition to perhaps the electronic health record?
So, great question. I would say technically we generally have the tools to make them successful. What they generally don't have is the time, right? We are in a situation where nationally, and I can certainly say in Arizona, we are under primary cared. Just overall.
Explain what that means.
Yeah, so for us, the ratio of a primary care physician to the population is out of balance. And so what that means, practically speaking, is if you need to see a primary care physician, either you're new to the area, if you have a new diagnosis, or you've had an exacerbation of a current condition, the likelihood that you get in when you want is more challenging than perhaps what it would have been 10, 15 years ago. We have, especially in like the Phoenix market, it continues to be a destination where retirees want to come, right? So we tend to have lots of folks who are new to Medicare who come there, which just adds more to the imbalance for, supply and demand, as well as a significant percentage of our, primary care providers in the market are approaching age 65 soon. And so that poses a unique challenge. So back to my, like what else do the physicians need? Well, of course, we can always integrate things a little better, give more bells and whistles, but we can generally tell them a lot about a member that's there with them, cost history, utilization, care gaps, coding opportunities, likelihood that they're high risk for some adverse event or some other clinical thing that we'd like them to do, or at least consider. But can they always get them in when they need to see them, and do they have the time at the point of care to always do all those things? And so, I would say our network is on board, but that's the challenge, though. Until nationally we see more contracts go away from fee for service to where really the lion's share. And I'll just speak for an independent physician. The vast majority of our providers we contract with, whether as a payer or as a clinically integrated network in our markets, are independent physicians. And so until we kind of shift that balance to where the majority of their total compensation or revenue for their practice is from value, we're competing, for their time, right? But so hopefully, as AI improves and there's other ways that folks can access care, we'll still preserve the what it means to be a primary care physician, have that relationship with a patient, and we'll still be able to get quick access when they need it through maybe some other means.
Well, let's talk about those other means. These days, when it comes to value-based care and population health, and you guys have done some amazing work in this space, and we've been proud to be a partner of yours in this work that you've done. Tell us a little bit more about what it means to be part of a care team, where the patient is working with the physician, but they're also working with a group of folks that are supporting different parts of their journey.
Yeah. So, there are, I'll use the example of some of the provider groups who are no longer, kind of onesie-twosie independent physicians, but have maybe joined some of the larger practice entities that are now employing physicians at an even higher percentage, where they're creating that model where you are joining a team. So it's not maybe, you as, let's say, the physician owner of a practice, maybe you got one or two APPs, you get an office manager, a collection of MAs. Your team on site is those folks that I said, but it may also include a clinical pharmacist, it might include a care manager, it may include a social worker or two, or other folks who have the time to sit down and really go deeper when somebody has something that needs their attention. And so we are seeing a higher percentage of practices, we are seeing a large number of primary care physicians join those types of environments, which is great because then it does allow them to practice in that way. They have someone they can hand the patient or member off to if they do have to move to the next room to see the next person. And we are seeing that there's lots of traction there, and we generally see a pretty significant improvements in outcomes and avoidable utilization, and are starting to see some really nice bumps from the member experience as well.
Well, that's fantastic. And I would imagine that those physicians who join a group like that, where they're getting some support through a care team approach, probably have less burnout as well.
I would imagine so. I think it's still hard for primary care physicians overall, just because all the demands that are there. Mm-hmm. But I would imagine that's probably partially being addressed. The other thing too, though, is what we do also as a health plan and as a clinically integrated network. Especially in the case where we're not the plan in our network don't employ physicians mm-hmm. directly. But we do employ many of those same team members that you spoke about. And so we, one of the things we do to, kind of enable their practice and their ability to succeed in this space is, especially if they want to maintain their independence and, still have their practice and their team, as we augment them with those tools. And so one of the nice things is we now have both the providers and, for example, our care managers, our care transitionalists, social workers, and others using the same platforms like EndNote, Patient 360, and other things. So they're at least kind of pinging a common space, since they generally are on their own electronic health record or one that they picked, right? And I will also say, too, our employed physicians through Banner Medical Group and Banner University Medical Group also have access to these great tools, even more integration with our team, just because we have more, relationships and ways to connect with them and their ops teams. And I will say that without adding that additional layer, for them to be successful in this space too, would have an adverse impact on burnout. So We, like I said, we still need more resources in general, collectively in healthcare, working on these things, and because we're all committed to bending the cost curve and really reducing avoidable utilization as best we can.
Well, that's fantastic. So, Ed, earlier you mentioned AI, and one of the things that there is a belief that with the appropriate types of AI solutions, we can actually help improve all the things that you just spoke about, helping the provider with their panel of patients, helping improve the overall cost of care, and maybe even doing so in a way that actually delights the patient as well. What thoughts do you have about the role of AI in the work that you're doing?
Very excited to see how AI augments that work, hopefully in some cases completely removing the work. But, I'm not unrealistic either. What I've kind of hoped for is if AI can maybe get us to the 1 or 2 yard line, and then we can have our brilliant clinicians and members of the care team then really kind of bring all that stuff together and then kind of add that human element and touch, really say, okay, yes, this patient or member now is going to benefit from a high percentage of these things it said, but really here's what we need to do for this member. So I'm just hoping what it can do, like I said, is reduce that burden upstream to where we can take quick action, tailor it to the member, and that'll somewhat perhaps offload the concern I mentioned earlier, right? Of like, do we not have enough primary care or other folks who are going into this space? So very interested to see what comes soon.
Yeah, I think as you think about AI, one of the things I'm told is that for doing these types of AI projects, whether we're augmenting the way that we do our jobs or whether we're completely replacing some low-value, high-effort tasks, the quality of the data is really, really important. And you spend a lot of time thinking about that because that's part of what is needed even to do the kinds of work that you're doing around the population health. What are some interesting advice that you would give to folks who are thinking about their journey into value-based care and the importance of data?
Yeah, so when it comes to the quality of the data, a few things come to mind just based on kind of lessons learned in the past, right? So I'd really recommend everybody pressure test everything, especially when it's new. I have yet to see a new dashboard or new report that's either landed on my screen or on my desk that hasn't had something that was unintended, right? Whether it was a code glitch or something else. So always make sure you get your clinical teams and others to pressure test things because we're not quite there yet on everything, right? And just let folks know too, especially if they're looking to AI or other things to kind of be this kind of holy grail, like, oh, this is the perfect way to outreach to a member or perfect list. I know that there's probably never going to be a perfect list, right? So don't think of it as this thing's going to be right 100% of the time. Think of it as this is going to be a dramatic improvement over what we've been able to share with you historically, because we want you to be as efficient as you can, at the point of care or at that time when you're making a decision based on this. So just kind of setting expectations, I think, is critical there.
Well, I really love the way that you're expecting a very pragmatic approach to all this and not expecting perfection in the data because, as you said, I don't think there is such thing as perfection in the data, especially when human beings are the ones who enter all this information. As we sort of think about other organizations that might want to start this journey, and you think about data, you think about analytics, you think about some of the areas to automate and even apply AI. If you could do it all over again, what would you do differently?
Wow, that's hard to answer because I've been at a couple of different organizations and was with Banner when we became the Pioneer ACO. Was there for a few years.
That was a while ago.
Left the organization, then I came back. So I'm just trying to think back. Oh, so I'll actually reflect on our Pioneer ACO days, and this is so there's some lessons learned here too. So we had a program at the time which was built around our highest utilizers of care. And so a care model was built, actually a whole team that worked out of a central hub. And this has been well documented and spoken about. great intent, and it was a high FTE model to focus on those highest spenders, and involving physicians, nurses, and others, and did great work, great intent, right? But hadn't maybe learned the lesson of regression to the mean. And so when you just go after those high spend folks, a lot of times, well, yeah, they had high spend because they had some unintended event, or they needed 2 total knees when they just got on Medicare or whatever, right? And so go into it with realistic expectations. I would say understand the degree of risk you're taking when you get into it first. So when I talk about risk, financial risk, right? Make sure that you've got alignment amongst all the folks on your team, and we've always had that. But if you're going to rely on a broader set of stakeholders to ensure success for you, whether that's in the ambulatory clinics and the hospitals or otherwise, it's just really good to make sure that they all understand the why behind it, because we still have a lot of incentives that work against each other at times, right? There's still a high percentage of folks who are in a fee-for-service model. So I would say that probably is the lesson I would tell folks if they're just starting out and their system or their community is relatively untouched in this space. I would just say really understand what levers you can pull, because if the vast majority of reimbursement in your area is on fee-for-service and you're trying to reduce costs, which is basically taking their revenue away, that can be really hard. And so
I can imagine so. So what I heard was that it's really around testing your assumptions and aligning your stakeholders so that there's a common purpose that's clearly understood. I think that's a great
Very well
place.
said.
I think that's a great place for us to wrap up. Ed, thank you so much for being a guest on our Xccelerate podcast, and we'll make sure that the references to that work that you've done previously makes it to our show notes. Thank you so much.
My pleasure.